eCancer was fortunate to get a meeting report written by Richard Shilsky for us. Rich Shilsky, as you know, is the Chief Medical Officer of ASCO and a very senior medical oncologist with many, many years of clinical investigation behind his belt. So Shilsky outlines in the meeting report a number of really interesting sets of new data, new approaches, looking at what to do with particular omics mutations, looking for the proteomics signatures which are now coming out of the labs, looking at new designs for clinical trials with the so-called umbrella model, where you take a random sample between a conventional treatment and whichever targeted therapy is dictated by the mutation analysis or the genomic analysis. And he himself summarized the meeting, and he indicated three difficult areas for the future. The first one is clearly that there is no consensus about how best to treat tumor samples and how to make sure that they are stored, having been properly processed in a way which would make data comparable between labs anywhere in the world. We've got a number of sets of guidelines on both sides of the Atlantic and also in Asia, but it's not yet clear that these guidelines are interchangeable, and if you took tumor samples from the biobanks in 5 random centers throughout the world, the processing would have been sufficiently identical to allow comparative results and to make you legally put the data together and exploit it and work on it. The second warning that Shilsky had was that we are in danger of being flooded by biomarkers which have not been validated. And he's calling on us in the translational medicine world, between the lab and the early clinical trials, to get cracking, to move faster on designing trials in which biomarkers will be a key endpoint, and after which we can either throw the biomarker out or continue to look at it in a more intensive way. We have too many biomarkers which are unvalidated, and this is essentially getting in the way of the science. We can't do good diagnostics unless you know that your biomarker works. So that was the second call for arms. And then the third issue he raised was patients' expectation. There have been very loose use of the word breakthrough in the media, in the newspapers, online, in television, and patients are expecting just that. Breakthrough means breakthrough. However, it's not clear for the average patient where they're going to go to get medical care which will deliver that breakthrough. And it's a challenge, I think, again, an organizational challenge for the oncology professionals to help indicate the pathway for the patient to the science which is integrated with the clinical care. And this is far from universal in cancer centers across the world, where the patient will have a better chance of getting better care because it's targeted to their particular profile with their cancer and also their particular psychological profile, etc. So we have to work a little bit on that. And in the meantime, as an editor of a very large online cancer journal, eCancer, I would really like to see us banning the word breakthrough in our news reports in the future. Next year, the WIN Symposium will be June 23-24 in Paris, and Shilsky is predicting that in addition to more mature data on genomics and on biomarkers, there will be more data on proteomic signatures and how they are going to help us get even more personalized. The second article in this month's review is from my own institute, the European Institute of Oncology in Milan, and it's required reading for oncology nurses. And it's required reading because it's describing the first oncology nursing minimum data set. It was in 1977, over 30 years ago, that an NMDS, a nursing minimum data set, was published in the United States. And this was general, and it described outcomes which were sensitive to nursing care in medicine. There is no, until now, there has not been an oncology specific nursing minimum data set. Alessandra Milani and her colleagues in the European Institute in Milan have investigated and worked out with a variety of techniques, with discussion groups, with role playing, and with very careful study of cases, what would be the outcomes which would be most useful for oncology nurses to use as outcomes on which they can measure the performance and improvements or deterioration. The nursing group in the European Institute in Milan assembled a group of specialists who were involved in care, including psychologists, dietitians, nutritionists, physiotherapists. They interacted with them, they discussed scenarios, and they came out with 49 items which were reckoned to be meaningful outcomes for oncology nurses. They clustered them together, and I got that down to 16. Looking at them, they seem to be so obvious, it's worthwhile asking why this has never been done before. The idea from now on is to take each of these 16 outcomes, group together in electrolyte balance, mouth care, ability to move, ability to cope on one's own, problems which are more medical, if you like, respiratory outcomes, skin outcomes, hand-foot syndrome, a number of these new problems which have come along with targeted therapies. And these need to be validated. So now you have in the public domain on eCancer the outcomes as they have found them, and this is a call for research nurses in oncology across the world to test them and to validate them, and please report your results back to eCancer. The third article, which I like very much, although it's not a randomized trial, it's not sexy in the terms of being stuffed full of genomics or proteomics. It's about managing new systems of delivering radiation therapy. And I say new, but in fact electron therapy using intraoperative radiotherapy dates back a lot of years. This is a very good, thorough study looking at the experience in the University of Madrid and the associated hospitals, and also the radiation department in Santiago in Chile, about the use of intraoperative radiotherapy in a variety of ways, in a variety of clinical conditions, and looking at combinations with conventional radiation therapy, with different kinds of surgery of different degrees of aggression, and with medicines. It's interesting because a lot of people who are not in the field have assumed that the most recent interest in partial radiation of the breast is a novel technology. Well, this paper from Calvo et al. Shows that it is not a novel technology at all. They report experience in over 1,000 patients over 17 years. Over half of them have got gastrointestinal cancers. There's a couple of hundred patients with sarcomas. There are children with pediatric cancer who have been given IORT, intraoperative radiotherapy with electrons, in addition to before or after, preferably after, it turns out, conventional radiation therapy. The interest in partial breast irradiation has spawned a number of conferences and not, unfortunately, too many randomized trials. One which is eagerly awaited is that from IO in Milan, the Elliott trial. But here we've got evidence, retrospective albeit, but carefully monitored, of added effect from IORT. Added effect in two ways. One is to add to the total dosage of radiation delivered by a treatment plan, but sparing toxicity because of the pinpoint accuracy of the electron therapy. Using after a tumour has been removed, to irradiate the resection edges just to make sure that there's no vital cells left behind, and using radiation therapy in awkward places where you're trying to get the dose as low as possible, for instance in pediatric cancers, and as targeted as possible. The bottom line is that that IORT does seem to be adding to the armamentarium of local treatment with the existing technologies of radiation and surgery, and that in GI cancers and in sarcomas, pancreas for instance, more randomized trials should now be being planned, because this technology looks as if it is indeed effective. These 3 papers can be downloaded on the eCancer app. You can do this onto your iPad, you can do it onto your iPhone, or you can do it on your Android phone. All of these papers, all the news items and the videos are all available at instant touch in your pocket.